The following podcast is part of a certified educational activity titled Innovative Approaches to Manage Primary Biliary Cholangitis, Charting New Courses of Care. Access the entire activity and complete the post-test at peerview.com/FEE860. Downloadable slides and practice aids are also available.
Welcome. Today we're going to discuss innovative approaches to manage primary biliary cholangitis, charting new courses of care. I'm Dr. David Bernstein, Professor of Medicine at the NYU School of Medicine. Our goals for today are to augment your knowledge of the diagnosis of PBC, to equip you with the strategies for implementing patient-specific care plans, and to provide guidance on recent efficacy and safety outcomes from clinical trials of drugs to treat PBC. Let's look at the criteria for early diagnosis and then timely initiation of PBC therapy. So primary biliary cholangitis is a slowly progressive autoimmune disease leading to injury of the small bile ducts within the liver, which can progress to cirrhosis and liver failure. It has the potential to have a significant clinical burden with complications such as fatigue, pruritus, jaundice, and cirrhosis and all of its complications. Because it's a chronic, long-term disease, it requires long-term medical care, which increases the overall healthcare burden. And that includes monitoring for disease progression, liver failure, and liver transplantation. As in any chronic disease, there are significant economic costs associated with this. Ongoing care, the cost of the medications, and the cost of any potential hospitalizations. PBC can lead to a significant decrease in overall quality of life by reducing physical, emotional, and social well-being. It also has a significant mental health burden, with increased risk of depression and anxiety seen in this condition. And then you have chronic fatigue, chronic pruritus, itching, leading to disability and the inability to actually work. These complications can interfere with relationships and with the ability to do personal activities. So these can have a really significant impact on the quality of life in a patient affected with PBC. The pathogenesis of PBC is actually quite complex, but it results of an exposure of an environmental mimic of a modified E2 subunit of the mitochondrial pyruvate dehydrogenase complex, which triggers an autoimmune response targeted against biliary epithelial cells. The adaptive immune system then activates itself, leading to the production of disease-specific anti-mitochondrial antibodies. And this is the key marker of the disease. Anti-mitochondrial antibodies target the immunodominant epitopes of the pyruvate dehydrogenase complexes in the inner mitochondrial membrane, and that contributes to biliary epithelial cell damage and apoptosis. Dysfunctional anion exchange sensitizes the biliary epithelial cells to apoptosis, exposes pyruvate dehydrogenase complexes in apoptotic blebs, which can then form antigen-antibody complexes, leading to cellular injury. The immune response becomes dysregulated with an imbalance between pro-inflammatory effector cells and regulatory T cells, which promotes ongoing biliary damage, and inadequate suppression of the immune responses leads to progressive inflammation, cholestasis, biliary fibrosis, and ultimately cirrhosis. So let's meet a patient who may have PBC. Let's talk about Debbie. Debbie's a 50-year-old woman with hypothyroidism and dyslipidemia. She comes in stating that she's been very tired and been having itching, especially in the evening. She says that it's been going on for at least 6 months with progressive fatigue and pruritus. She describes the fatigue as constant, severe, unrelieved by rest, and significantly impacting her ability to do her activities of daily life, both at home and at work. And she describes the pruritus as present but particularly troublesome at night, disturbing her sleep, and she doesn't sleep well. She doesn't have any history of abdominal pain. She doesn't have any weight loss. In fact, she eats well. She occasionally reports feeling bloated. So you suspect that she may have PBC. So how would you assess Debbie? Right? And what would you recommend to determine whether or not she has this condition? Well, we start with looking at the key symptoms in your mind, right? The key symptoms of PBC are fatigue, pruritus, brain fog, body aches and pains, dry eye, dry mouth, or Sicca syndrome. But it's important to note that most patients with PBC are asymptomatic and feel fine. And their diagnosis we'll talk about by abnormal blood testing. The physical exam in patients with PBC is also mostly normal. If there's going to be something abnormal, you may find an enlarged liver, an enlarged spleen, or the presence of xanthelasmas, cholesterol deposits on the skin. Epidemiologically, most patients with PBC are women, in fact 90% of cases, but 10% are men. Typically this is diagnosed in people between age 30 and 60, but mostly people in their 50s and 60s. And it's associated with many autoimmune disorders, but the most common are thyroid disease, Sjogren's syndrome, which leads to dry eyes, dry mouth, rheumatoid arthritis, and celiac disease. The diagnosis of PBC is made by having at least 2 of the 3 diagnostic criteria. The first is an elevated alkaline phosphatase, which is a blood test. The second are autoantibodies, an anti-mitochondrial antibody, which is positive, or an ANA-specific positive antibody, either an anti-GP210 or an anti-SP100. The third component for diagnosis would be a liver biopsy consistent with PBC. Since the vast majority of patients will have the first 2, an elevated alkaline phosphatase and an AMA, a biopsy is seldom necessary for making the diagnosis of PBC. We do use it when we're unsure of a diagnosis. We do use it when we're concerned about an overlap between PBC and other liver conditions. We used to use it more in patients newly diagnosed to determine prognosis, but now we have non-invasive markers of fibrosis which can be used. So the majority of patients that we're going to see are going to have an elevated alkaline phosphatase with a positive AMA or a positive ANA-specific antibody. So if we take the typical presentation and clinical findings in PBC, most patients are diagnosed when they're more than 45 years old. 90% are female, 10% are male. Most patients are asymptomatic, but if they're going to have symptoms, it's fatigue, pruritus, dry eyes, dry mouth, joint pains. Some have abdominal pain. 95% will have a positive anti-mitochondrial antibody. 30 to 50% will have a disease-specific ANA, which is positive, the GP210 or the SP100. And some patients may have low levels of anti-smooth muscle antibody. Serum immunoglobulin IgM is typically elevated. In the blood test, the alkaline phosphatase is typically elevated. And on imaging, whether it be an ultrasound, a CAT scan, or an MRI with MRCP, the bile ducts are normal, which differentiates this condition from primary sclerosing cholangitis. When a liver biopsy is performed, typical findings are a lymphocytic infiltrate, inflammatory reactions around the small bile ducts in the portal tracts, and the presence of granulomas. And these are not specific for PBC, but in combination with either an elevated alkaline phosphatase or an AMA positive are diagnostic of PBC. So now let's talk about treatment. And let's talk about efficacy and potential safety insights. And let's come back to Debbie. You've taken her history, now you examine her. Her vital signs are normal. Her physical exam is normal. Blood tests show an elevated alkaline phosphatase of 420, a total bilirubin of 0.8, which is within the normal range. Her transaminases are mildly elevated, remembering that a normal ALT for a woman should be 25 or less. Her antimitochondrial antibody is positive, strongly positive. Her serum IgM is elevated. Her anti-GP210 is positive and elevated. Her thyroid function is normal, and her cholesterol panels are normal. So now you feel comfortable that you've diagnosed Debbie with PBC. What would you recommend for treatment? And now we have to go into a discussion of how we treat PBC and what the goals of therapy are. First thing we do is stratify the disease risk, and we'll go over that. And then start first-line therapy, which is ursodeoxycholic acid. The initial goals are to improve the patient's symptoms and to improve biochemistry, bring the alkaline phosphatase down, bring the bilirubin down. Ideally, we'd like to normalize those, but the current accepted number for a complete response in a patient treated with PBC is an alkaline phosphatase less than 1.67 times the upper limit of normal. Over time, and treatment is lifelong once it's begun, the goals are to reduce fibrosis, increase transplant-free survival, and to normalize a patient's quality of life. So these are lofty goals, but with this condition, we're able to reach many of these. In the beginning of therapy, we assess someone's risk, and that's very important. On the left side of the slide, you can see some characteristics of patients who are at low risk of disease progression. They are those patients with a higher age at diagnosis, no advanced fibrosis at diagnosis, they don't have any concurrent liver diseases, such as autoimmune disease or fatty liver disease. They're started and have an adequate response to ursodeoxycholic acid, and they have a GLOBE score of less than 0.3, and the GLOBE score is one of the scores that we can use to assess response to therapy, and we'll talk about that in a bit. Biochemically, those patients who start at lower alkaline phosphatase and bilirubin are at low risk. Those that are GP210 negative have a lower risk of progression, and those whose non-invasive imaging show less scarring, and here a KPA of less than 10, are all part of the group on that low risk category. On the right, we see those patients that are of a moderate to high risk of disease progression. Patients who are diagnosed when they're younger. Patients who are diagnosed with advanced fibrosis at diagnosis. Those who have concomitant liver disease, such as fatty liver disease or autoimmune disease. Those who were started on ursodeoxycholic acid and have an incomplete response, and those whose GLOBE scores are greater than 0.3. Biochemically, those patients who start out with a high alkaline phosphatase and high bilirubin are at a higher risk of disease progression. Those who have a positive GP210 are at a higher risk of disease progression. And those who have advanced fibrosis diagnosed by transient elastography, here a KPA of greater than 10, consistent with bridging fibrosis, are at higher risk of disease progression. So we stratify patients from the beginning. So that's how we evaluate their liver disease. Then we discuss the second component, which are the symptoms associated with the disease: fatigue, pruritus, brain fog, dry eyes, dry mouth, the other autoimmune diseases that may need to be assessed and treated. Assessing bone densitometry, since osteoporosis is associated with this, and we'll talk about this in a bit. Whether or not they have abdominal pain. Those patients who are cirrhotic are at increased risk of developing liver cancer and need to be screened. Discussions around patients' concern for pregnancy. And then when we talk about the therapies we're going to use, what are the potential side effects of those treatments? And what happens in these patients, they can progress, and they progress slowly from asymptomatic to potentially symptomatic to advanced disease that requires attention of liver subspecialists. So let's talk about first-line therapy for patients with PBC. First-line treatment, as I mentioned earlier, is ursodeoxycholic acid. That is effective in bringing down the alkaline phosphatase to what we determine a response of 1.67 times the upper limit of normal in approximately 50 to 60% of patients who are treated. But that also means that about 40% of patients will not achieve that adequate biochemical response. And there's a subset of patients, about 5 to 10%, that are unable to tolerate ursodeoxycholic acid because of side effects. The side effects are predominantly GI side effects, nausea, diarrhea, and abdominal pain. Also, especially in women, there can be hair thinning that can be problematic for patients. So we treat with urso to bring the numbers down and to prevent progression of fibrosis. But urso doesn't treat the associated symptoms, such as fatigue or pruritus. Because again, PBC, we treat the liver, and then we treat the side effects. And they're not necessarily related. So the other thing we've learned is the lower we can make the alkaline phosphatase with therapy, the better patients do. Currently, the accepted response rate is reducing the alkaline phosphatase to 1.67 times the upper limit of normal. That was defined in clinical trials as a response. But as we're getting more and more data, we're learning that normalization of alkaline phosphatase may be better. And it actually makes sense. So especially in a patient that has baseline fibrosis, you would really want to bring the alkaline phosphatase down to as low as possible and ideally within the normal range. Ursodeoxycholic acid is dosed by weight, and it's dosed at a dose of 13 to 15 milligrams per kilogram. The current recommendations are to evaluate patients at 12 months after treatment initiation to determine whether or not they're having a response and second-line therapy is indicated. These recommendations come from the AASLD guidance documents. But the AASLD guidance documents were written before we had newer agents. And the newer agents which were approved in 2024 are Seladelpar and Elafibranor, which are PPAR agonists. Because of this, we now make an assessment with patients to see whether or not they're having an adequate response at 6 months. It just makes more sense because we've learned is we'd like to get that alkaline phosphatase down. And why should we wait 6 more months when we have good second-line therapies in the patients who don't have an adequate response to ursodeoxycholic acid? So about 40% of patients do not have a complete response to ursodeoxycholic acid, and about 5 to 10% of patients are unable to tolerate it. In those patients with fatigue or pruritus, urso doesn't help. We have to think of other ways to relieve the symptoms. So urso will treat and bring down the biochemistry and may prevent or reverse hepatic fibrosis, but it doesn't treat the other symptoms of PBC. So let's go back to Debbie. We started her on ursodeoxycholic acid, and she's followed for 6 months. Her labs are repeated, and her alkaline phosphatase is 320. And if you remember, her baseline was 420. So she hasn't come down as much as we'd like in 6 months. Her bilirubin is approximately the same. She started at 0.8, and now it's 0.9. But she continues to experience pruritus, itching, and fatigue. So what would you do now in this patient, considering she has not had an adequate response to treatment? And here's where we talk about second-line therapies. What can we offer patients? And who needs those second-line therapies? And here you can see from the AASLD guidance document a list of different formulas that can be used to assess whether or not a patient is having an adequate response to therapy. The easiest one is to remember you want to get patients down to below 1.67 times the upper limit of normal. I mentioned earlier the global index, right? You want patients to be within 2 times the upper limit of normal. And those patients are more likely to have less risk of disease progression. But we really make a determination as to whether or not we're going to add second-line therapy based upon the biochemical response. We have 3 choices for second-line therapy and 2 different classes of medication. We have an FXR agonist called obeticholic acid, and we have 2 PPAR agonists called Elafibranor and Seladelpar. The AASLD guidance document on second-line therapy recommends that patients who do not have an adequate response to ursodeoxycholic acid should be considered for second-line therapy treatment with obeticholic acid starting at 5 milligrams per day. Off-label fibrates can also be considered in patients with PBC who have an inadequate response to ursodeoxycholic acid. It's important to keep in mind that these guidance statements were written before we had the second-line therapies of Seladelpar and Elafibranor. So our actual practice has changed since those 2 therapies have become available to us. If we look at obeticholic acid and we look at the POISE trial, and we see here that this was a large 3-arm placebo-controlled study of obeticholic acid 10 milligrams a day, obeticholic acid 5 milligrams a day with step up to 10 milligrams a day versus a placebo, we can see in the first 12 months depicted on the left of this graph, significant improvement or significant response in those patients who received obeticholic acid. In both groups, the 10 and the 5 to 10 milligram dosages, dramatically better than those who received placebo. In the right-hand portion of this slide, when placebo patients were then given obeticholic acid, they also had an improvement. So about 50 to 60% of patients treated with second-line therapy with obeticholic acid had a complete response. If we look at the main adverse event associated with obeticholic acid, it is pruritus. And so we can see that patients with PBC develop pruritus, and we can see that from the placebo arm. It's part of the disease. Remember, these are patients who were on ursodeoxycholic acid. But there was an increase in the degree of patients presenting with pruritus based upon obeticholic acid and its dosage. So 56% of the patients treated with obeticholic acid in the 5 to 10 milligram dose developed pruritus, and almost 70% of the patients treated in the 10 milligram dose developed pruritus. 1% of the patients treated in the step-up arm had to have the obeticholic acid discontinued for pruritus, and 10% in the higher 10 milligram arm. So pruritus is something to consider and to manage in patients that are being started on obeticholic acid. Let's move to the newer therapies now, the PPAR agonists. And these are peroxisome proliferated activated receptors. And they are involved in cholestasis, decreasing inflammation, decreasing fibrosis. And we look at alpha and delta PPARs for the treatment of patients with PBC. So if we look at the first PPAR that was approved for patients with PBC, that's called Elafibranor. It's a dual PPAR with alpha and delta agonist properties. Both lead to anti-inflammatory effects. The alpha portion decreases bile acid synthesis and modulates bile acid output. The delta promotes bile acid transport, and both together decrease the toxicity of the bile. This was approved in June of 2024 for patients without cirrhosis and for those with compensated cirrhosis, at a standard dose of 80 milligrams a day. The Elative trial was the trial which led to the approval of Elafibranor. This was a double-blind, randomized, placebo-controlled, phase 3 trial to evaluate the safety and efficacy of Elafibranor given once daily in patients with PBC who had an inadequate response or who were intolerant of ursodeoxycholic acid. The key inclusion criteria were patients had to be on a stable dose of ursodeoxycholic acid for at least 12 months. They had to be between ages 18 and 75. Their alkaline phosphatase had to be greater than 1.67 times the upper limit of normal, and they had to have a total bilirubin of less than 2 times the upper limit of normal. It's important to note for this study, the upper limit of normal of alkaline phosphatase for women was defined as 104, and for men, 129. Patients were randomized to Elafibranor plus urso versus placebo plus urso, and the primary endpoint was a composite endpoint of decreasing alkaline phosphatase to less than 1.67 times the upper limit of normal, with at least a 15% decrease of alkaline phosphatase from baseline, and a total bilirubin decreasing to within the upper limit of normal range. There were certain select secondary endpoints: normalization of alkaline phosphatase, reduction of itching complaints, and overall delta change in alkaline phosphatase. And so, very straightforward, well done study. If we look at the biochemical response here on the left, we can see that 50%, approximately 50% of the patients who were treated with Elafibranor plus urso had a biochemical response. 15% of them normalized their alkaline phosphatase. And on the bottom right, you can see there's a trend towards improvement in complaints of itching when this medication was used. Right? And that's a plus, because remember we talked earlier as pruritus being a complication or complaint related to this condition. There were not any significant adverse events which were noted compared to placebo, except for there was an approximate 6% fracture rate in the Elafibranor arm compared to no fractures in the placebo arm. And it's important to note that there are certain important drug-drug interactions that one needs to be aware of when using Elafibranor. Elafibranor reduces the exposure of progesterone and ethinyl estradiol, which can lead to contraceptive failure or breakthrough bleeding. Patients who are co-administered with an HMG-CoA reductase inhibitor, statins, can have an increased risk of myopathy. So therefore, periodic monitoring of CPK is important. And co-administration of rifampin may reduce systemic exposure to Elafibranor. So if we summarize Elafibranor, it's a PPAR alpha and delta agonist with a single 80 milligram dose, which can be taken with or without food. 51% met that composite endpoint. 15% had a normalization of the alkaline phosphatase. There was a numerical improvement in pruritus without statistical improvement, and there was an approximate 6% fracture rate seen in the group that received Elafibranor. If we look at the second PPAR agonist, which was approved, this is Seladelpar. This is a delta agonist only, and this was approved in August 2024 for the treatment of patients with PBC without cirrhosis or with compensated cirrhosis at a dose of 10 milligrams a day. It's just important to note that both PPARs are approved for non-cirrhotics and those with compensated cirrhosis, but are not approved for patients with decompensated disease. Seladelpar has been shown to improve cholestasis, reduce inflammation, reduce pruritus, and increase lipid metabolism. And it's therefore a selective PPAR delta agonist with anticholestatic, anti-inflammatory, and anti-pruritic effects. The response study, similar in design to the Elative study for Elafibranor, was a trial 12-month long of Seladelpar 10 milligrams versus placebo. Most of these patients were on ursodeoxycholic acid. The key inclusion criteria were similar to the previous study with Elafibranor: inadequate response or intolerance of UDCA, an alkaline phosphatase of greater than 1.67 times the upper limit of normal, a total bilirubin of less than 2 times the upper limit of normal, and an AST and LA-ALT less than 3 times the upper limit of normal. And in this study, compensated cirrhotics were included. Patients were randomized to Seladelpar versus placebo, that I had mentioned. The primary endpoint is a composite endpoint, similar to the previous study we discussed. Alkaline phosphatase less than 1.67 times the upper limit of normal, with a decrease in alkaline phosphatase of greater than 15%, and a total bilirubin within the normal range. Secondary endpoints were alkaline phosphatase normalization at 12 months and changes in pruritus. So if we look at the results with Seladelpar, you can see the composite biochemical response was 61, almost 62% in the patients who received Seladelpar, and 25% of those patients had a normalization of alkaline phosphatase. In the graph in the top right, you can see the decrease in alkaline phosphatase occurred quickly, within the first month, and then stayed that way throughout the remainder of the trial. And in the bottom right, you can see the graph which shows the improvement in pruritus. And here, there was a statistically significant improvement in pruritus in the patients who were treated with Seladelpar. So here we're treating both the hepatic component and the complications of disease with a single medication. There were no significant adverse events noted when compared to placebo with Seladelpar, but there was a 4% fracture rate in the Seladelpar arm compared to none in the placebo arm. There are certain drug-drug interactions that one needs to be aware of. Should not use this with O3 inhibitors. Patients with a strong CYP2C9 inhibitors such as amiodarone shouldn't be taking it. And in patients that are receiving rosuvastatin, glyburide, nitrofurantoin, chlorothiazide, or sulfasalazine, you should monitor closely for adverse events. But in general, very well tolerated medication. So if we summarize Seladelpar, it's a selective PPAR delta agonist, single dose of 10 milligrams orally with or without food, composite index of 62% meeting that, 25% normalized their alkaline phosphatase, statistically significant improvement in pruritus, and a 4% fracture rate in the group that received Seladelpar. If we compare the two, they're quite similar, and both have been a major advance to our armamentarium to treat patients with PBC who have had an inadequate response to ursodeoxycholic acid or who were unable to tolerate ursodeoxycholic acid. Alkaline phosphatase normalization wasn't reported with obeticholic acid, 15% with Elafibranor and 25% with Seladelpar. And the overall alkaline phosphatase reduction was similar between the 3 different therapies. And it's important to note that we're talking today only about those therapies that are approved for use in the United States. There are fibrates that are used in Europe, but they're not available in the United States, so they're not included, in our discussions. So now we've talked about how we treat the disease state itself. What about the symptoms and complications that are associated with PBC? And the main ones are, again, pruritus, fatigue, dry eyes, dry mouth, metabolic bone disease, and dyslipidemia. Right? Significant numbers of patients with PBC have pruritus. And the key to figuring out who has pruritus with PBC is actually asking them. It's very important to ask your PBC patients at each visit if they have itching. So let's come back to Debbie. If you remember, after 6 months of an inadequate response to ursodeoxycholic acid. She was started on a PPAR. She comes back now after 6 months, and her alkaline phosphatase and bilirubin are normal. Her fatigue is better. She continues to have some pruritus, which interrupts her sleep and affects her activities of daily living. So now we need to focus on how do we assess and how do we treat Debbie's complaints specifically related to her pruritus. AASLD states in their guidance document of 2018 that the symptoms of PBC significantly impair quality of life and do not typically improve with UDCA or obeticholic acid. So they warrant separate evaluation and treatment. EASL, which is the European Association for Study of Liver Disease, in an older guideline, recommends that the evaluation of all patients for the presence of symptoms, in particular pruritus, dry eyes, dry mouth, and fatigue, because we need to assess these. About 70% of patients with PBC will have pruritus, whether it's a daily event or an intermittent event. And again, it becomes so important that we ask our patients about itching each time that they're seen. How do you do it? There are lots of scales that one can use, but the reality is they're very impractical to use in clinical practice. I always think it's best to keep it simple. Just ask, are you having any itching? Does it bother you? If the answer is yes, rate it. If you would say a scale is 0 to 10, 0 doesn't really bother me, or none, and 10 is the worst, what is it? And patients are pretty good at this. And a score of 4 or greater typically indicates moderate to severe itching. And there's where we're going to want to have some sort of intervention to help the patient. The initial management is common sense. Many times it can be related to dry skin, so moisturizers will help. Good sleep hygiene is helpful. A nice cold shower before bed may help. Melatonin can help. Since patients are always scratching, it's important that they cut their fingernails down to avoid scratch marks, excoriations, which can lead to infection. Loose-fitting clothing should be recommended and made of natural fibers like cotton. It would be a good idea to avoid woolen clothing and tight-fitting clothing. They tend to cause more itching. Avoid overly scented detergents, which can worsen pruritus. Consider antihistamines, which may be effective in some patients. And there are some who advocate over-the-counter primrose oil, 2 grams twice a day, to help improve pruritus before moving on to medications that are prescribed. If you reach the point that all of the first steps do not work, then we really go down a path of stepwise approach to managing pruritus. And we start with cholestyramine, an anion exchange regimen, which is a powder that needs to be mixed with a fluid and taken one times a day to 4 times a day. Because it's an anion exchange resin and a binder, it will also bind medications that people are taking. So they then therefore have to take all the other medications either 2 to 4 hours before or after the cholestyramine. Cholestyramine has some side effects. It can cause bloating, it can cause constipation, conversely it can cause diarrhea, and it can also cause nausea. If that works, great. If it doesn't, we go down and we can try something like rifampin, which is a PXR agonist which lowers the enzyme autotaxin. But there are numerous drug-drug interactions associated with rifampin, and it's important to remember that rifampin can cause urine and tears to turn yellowish. And so patients need to be told that because it's not a good idea to wear contact lenses and actually take this medication. And there is a risk of developing drug-induced liver injury in a hepatocellular pattern within the first 2 months. Next, you can try naltrexone, which is an opioid agonist. Works fairly well. Can lead to loss of appetite and some irritability. There's GI side effects associated with it. And if started, you can't just stop it because withdrawal symptoms can occur. And then we come to the bottom here, which is sertraline, which is an SSRI, which is what I tend to use if cholestyramine isn't effective. It works fairly well, but it can be associated with side effects such as somnolence, nausea, dizziness, and fatigue. And it also may improve depression if a patient has underlying depression. There are ileal bile acid transport inhibitors, or IBAT inhibitors, which treat cholestatic pruritus very well and are approved for Alagille syndrome and PFIC, but they're not approved for PBC. And you can see them listed here. These work very well, but once again, they are not approved for the treatment of primary biliary cholangitis. But you should know that these are out there, and we'll see what happens in the future. There are investigations into IBAT inhibitors for treating PBC-related pruritus. The Glimmer trial you can see here, which is a phase 2b trial of linerixibat, and it demonstrated the primary endpoint was a significant improvement in pruritus in patients. So here's something that certainly can be effective. And there's a study, phase 2 study looking at volixibat, as well. So I think you're going to be hearing more and more about IBAT inhibitors to be treating the pruritus related to PBC in the future. And it's nice to see that not only are we advancing for the treatment of the disease state, but also for the side effects or the complications. What about managing dry eyes or dry mouth? Well, artificial tears and artificial saliva can help. Pilocarpine certainly helps for dry eyes and can be used for refractory symptoms. Fatigue is really difficult. We don't have good therapies for that. And so the key is to try to determine if something else is causing it. Most common cause of fatigue is that patients don't sleep because they're itching. And so it becomes a cycle. So assess them for their sleep habits, but also ensure they're not anemic, they don't have hypothyroidism, and they don't have depression. So the evaluation of fatigue is really looking for another cause and then having a discussion about their sleep. There is no medication to treat fatigue. Patients with PBC can develop metabolic bone disease. Osteoporosis is common in this patient population. Osteomalacia is less common. I think what's important to realize is that these patients should be assessed regularly with DEXA scanning for the presence of osteoporosis, and they should be treated for osteoporosis if they develop it. In addition, before they develop osteoporosis, they should be placed on calcium and vitamin D. And that's a significant component of how we treat patients with PBC. So how do we treat? This is sort of a review. Calcium, vitamin D, biphosphonates, and one can consider estrogens, but they're really not the first-line therapies because of complications. All the patients with PBC should be on calcium and vitamin D, and then if they develop osteoporosis, they should be treated accordingly. Many of these patients will have high cholesterol levels. In early disease, you'll see a high HDL, a high LDL, and a high VLDL. In later stage disease, you'll see a low HDL and a high LDL. In patients with significantly elevated cholesterol, more than 600, you can see xanthomas and xanthelasmas, and that needs to be assessed. What's interesting about PBC, despite the dyslipidemia, that there does not appear to be an increased risk of ischemic heart disease or stroke unless the patient has another underlying medical condition or a separate lipid disorder. And so there has to be a discussion as to when patients with dyslipidemia and PBC are actually treated. Statins are safe for use in patients with PBC. So if we summarize the treatment then of patients with PBC, the first-line therapy is ursodeoxycholic acid. If that's ineffective or the patient cannot tolerate the medications, then we have a choice, an FXR agonist, a beta-cholic acid, or one of the PPAR inhibitors, Elafibranor and Seladelpar. If the patient progresses to cirrhosis and complications, transplantation is an option, and these patients can do well with liver transplantation. So to conclude, PBC is a chronic progressive autoimmune cholestatic disease with simple diagnostic criteria. 2 of the 3, elevated alkaline phosphatase, positive antimitochondrial antibody, or a biopsy consistent with it. 2 tiered therapies. We treat the liver disease, and we treat the complications and associated diseases. We treat end-stage disease with transplantation, but the key to success is early diagnosis and treatment. And that will save lives and improve quality of life over time. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by independent medical education grants from GSK and Ipsen Biopharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/FEE860.